My name is Sanjeev Bhalla, and I'm a professor of radiology at Washington University, and I run the cardiothoracic imaging section here at the Mallinckrodt Institute of Radiology in St. Louis, Missouri. As a chest radiologist, one of the things that's true is the modalities that we frequently read studies in include radiography, it includes computed tomography. But one that I've really become very fond of in recent years has been chest MRI. MR really gained prominence with neuro applications and with musculoskeletal applications because those organs, the bones and joints and the brain, tend not to move with respiration. So they're very amenable to studies that require minutes, tens of minutes to be performed. Now, recently, cardiac MRI has become very useful for looking for infiltrated diseases of the heart, to evaluate cardiac function and look at some of the blind spots that echo may not be able to pick up, including and especially the right ventricle. So we do a lot of cardiac MRI and the evaluation of patients with pulmonary hypertension. But an area of my interest and in our section's interest here at Washington University has been looking at thoracic applications of MRI outside of the heart and great vessels. And we have found that it's really very useful and often underused because I think we don't learn about it during medical school, nor do we really talk about it much during fellowship. So MRI in our practice is really useful for looking at mediastinal masses. So if you're looking at a mediastinal mass, especially one that looks cystic on CT, MR is a great way to evaluate. MRI has not as good spatial resolution as CT, but it has much better contrast resolution. So it allows you to see that, oh, that thing that looked like a cyst on the CT turns out to be something that is more of a solid lesion. And so when we have a posterior mediastinal mass and we're worried that it is potentially a posterior mediastinal cyst, which is very weird, an MRI will show us that it's a neurogenic lesion like a schwannoma with no problem. In the anterior mediastinum, it's useful because if you see a cystic lesion, the question might be, is it a thymic cyst where we do nothing, or is it a germ cell tumor which requires the patient to get this excised? And what we found is that it's really useful for the evaluation of these cystic lesions. And so if we do an MRI with and without contrast and we see that there's enhancement, that will help steer us towards a germ cell tumor. If we see that it has some internal fat or fatty elements, that will also help steer us towards a germ cell tumor as well. Another is if that anterior mediastinal lesion is actually thymic tissue or thymic hyperplasia, there may be a role for us to do in and post-phase imaging to see if there's dropout. So in our practice, when we have patients who've got these complicated mediastinal lesions, then we find that MRI is really useful for further characterization. We just had a case a few weeks ago of a patient who had a weird looking anterior mediastinal mass on a chest CT. We did the MRI and it allowed us to really appreciate that the brachiocephalic vein, which was traveling through this mediastinal mass, was actually thrombosed, and it was thrombosed with bland thrombus. And then it turns out that what we were seeing in the anterior mediastinum was simply edema of the thymus related to the thymic vein being thrombosed. And so it's nice to have that added ability to at least guide our surgery colleagues and our oncology colleagues as to what to expect. We might not avoid biopsy or resection completely, but it allows expectations to be aligned. A third area that we found that MR is really useful is for looking at the pleura. So a mesothelioma can present with a chronic pleural effusion, and even after a thoracentesis or a VATS, a diagnosis might not be made. So the benefit of an MR is that when we're all thinking that it could be either endometriosis of the pleura or mesothelioma, is it allows us to look for subtle areas of nodular enhancement, which can then be used for targeting for biopsy or for VATS if needed. And so we find that it's really, really good for looking for that. There are other experimental areas that people have talked about MR, looking at nodule characterization or nodule screening. We haven't found that to be so useful in our practice yet. We're hoping one day we'll get there. But that can be some potential future goal. But one other final area that we found useful is if the question is if vital structures are being invaded by a lung cancer. So we've had a few cases where the question is, there's a tumor that's next to the aorta. Is it invading the aorta? So with some of the new MRI sequences, you can do real-time breathing. So you can look at, does the tumor slide next to the aorta with breathing? And so that allows us with confidence to say, no, it's not involved, or to alert the surgeon that maybe the tumor is involving the aorta, or maybe the question is it involving the brachial plexus? So for superior sulcus tumors, useful. And then finally, if you've got somebody who's like got a sarcoma of a pulmonary artery, and the question is if they're resectable, it's useful to know, is it involving just one of the pulmonary arteries, or did it cross over to the other side? An MR can be very useful, especially with the synase during the cardiac cycle, to see how it moves. So we find that MR is still, it's a problem-solving tool. We rarely use it as a first-line imaging modality, but if used well, can be really good for aligning expectations, especially if somebody's going to be going to the operating room.